first of all, thanks Bob and Cheryl and all of the organizing committees for inviting me again this year. It's always a pleasure to speak to the lay public. Public education and decision making is very close to my heart. As you know, I've been into writing for the lay public and speaking for many, many years. I think it's very important for people to have a better idea of what they're facing to help them make an informed decision. Now, Bob asked me if I would speak on the development of a men's health initiative in British Columbia, which was kicked off this past spring with a fundraiser in Vancouver. And I'm going to do that, but then I thought I should also present something on prostate cancer in particular, given the audience that's here. And I think that I'm going to find a balance this morning. Now, I have two talks to follow the Men's Health Initiative. One is on HIFU, the other one is on penile rehabilitation following surgery. If I only have time for one of them, which would you prefer? HIFU, put up your hands. Penile rehabilitation, put up your whatever. All right, very few hands went up, so I'll hopefully get all three of them. So, our world has changed. As you know, it took over 11,000 years for the population on Earth to reach 1 billion in the year 1804, but only 123 years in 1927 to reach 2 billion. And today, we're sitting at 6.5 billion and growing. And when we look at the demographics of our world, it really does impress upon you that it's not surprising that we're running into issues with climate, with food, with fuel, and so forth. And this just shows the life expectancy across the world of men being 65 and of women 69. I think I can use the pointer here. And if we look down across North America, including Canada, there's about a 6-year difference between men and women. But the life expectancies are not too bad, considering. And that's because whether it's medical care, better eating, better exercise, better awareness, or whatever, people are living longer. In 2006, there are 6.5 billion people on Earth, 10.5% of whom are over the age of 60. So we now have 688 million people over the age of 60 on Earth. By 2050, when the population of the globe will be over 9 billion, the percentage of men and women over 60 will be 21% of that, or 1.9 billion people over the age of 60. When we look at the demographic trends, it underscores the fact that our current situation today in 2008, and future trends really has to concern us. Aging is really the reality of our world. This just repeats what I showed in the previous, where in 2006, about 11% of the population is over 60, and that's going to go up to 22% by the year 2050. The impact of that, and I quote a friend of mine, Dr. Bruno Lunenfeld from Israel, who presented this past spring. The 20th century was the century of population growth. Historically unprecedented declines in mortality rates and increases in population, followed by equally unprecedented declines in fertility rates in most countries around the world. The 21st century will be the century of aging, with a new set of demographic challenges, including falling fertility rates, alongside the subsequent aging of populations in both developing and developed countries. And as you know, aging is not always pretty. I point out the governor of California, and this is the Staying Alive fellow. I don't know if that's his arm on your poster or not, but John Travolta certainly looks a little different now than he did when he was dancing. And of course, I had to throw in a little Canadian content to meet the Canadian standards, otherwise I wouldn't be able to give this presentation. But the reality of our aging world is that the projected 2 billion elderly people of the year 2050 are already around us. They're alive, they're teenagers, they're young people. And we have reorganization of our world and intergenerational relations are reflected in the coexistence of 4 and sometimes 5 generations in the same home, at the same time, in the same place. And one of the consequences of this is a declining labor force, as the increasing percentage of the elderly who don't work keeps going up and up. And that's compounded by a simultaneous decrease in the population of children because of declining fertility rates. Who's going to be working? Who's going to look after the elderly? So a declining labor force will have to support a growing number of elderly. That is a truly scary thought. These demographics are for real. And this just shows the same thought in a table form. The potential support ratio, that is the number of persons less than age 65 who will be alive to look after people over the age of 65. In 2006, around the world, it's about 9 to 1. And by 2050, it will be 4. So you're going to have a decreasing number. And look at Europe down here. And in Italy, I believe the projection is 1 to 1. For every elderly person over 65, there'll be one young person to look after that individual. The other consequence is a socioeconomic strain. So since the last years of life are accompanied by an increase in disability and sickness, the demand on social and health services will increase immensely. The high cost of these services will strain the ability of health, social, and even political infrastructures to cope, and intra-family caregiving patterns will necessarily change. Just read the Dr. Seuss, The Cat in the Hat on aging. I cannot see, I cannot pee, I cannot chew, I cannot screw. Oh my God, what can I do? My memory shrinks, my hearing stinks, no sense of smell, I look like hell. My mood is bad, can you tell? My body's drooping, have trouble pooping. The golden years have come at last, the golden years can kiss me. So what we do, because of the numbers of people, I mean, it's great, we're all living longer. People say today 70 is, yesterday's 55, and people are routinely living into their 80s. Well, it's great, except there's a big gap. There's a gap between life expectancy and what we call health expectancy. And this is a new health indicator that the World Health Organization came out with about 15 years ago. And what it refers to is disability and functional dependence-free life expectancy. So you can live to be 80, but if you're crippled for the last 15 years of your life, and you're a huge burden on your family and on society, is that a good thing? And if you look at the table here from 2005, the health expectancy is shown down the left side here, the life expectancy is here, and the difference, the gap between life expectancy and health expectancy is about 10 years across the world. So that means the last 10 years of your life, you ain't too healthy. And so what we want to do through the programs that I'm going to be talking about in a short minute or two is decrease the gap between life expectancy and health expectancy. Grow older without growing old. Aim at maintaining functional capacity, delaying frailty as long as possible, and total dependency through the maintenance of physical, social, and spiritual activities throughout a lifetime. And so your motto for this meeting is staying alive. I think it's staying alive and staying healthy is really what we have to aim for. And wouldn't it be all wonderful if we could be healthy until our last breath? Of course, that's not a reality, but we can certainly aim to decrease the gap, between the life expectancy and health. So how do we do that? How can we decrease this gap? Well, we need centers and networks of excellence are the only way forward to ensure that the aging population receives consistent, cost-effective, evidence-based care. Clinical excellence can be achieved by proper education, adherence to evidence-based guidelines and standards of care, and quality management and continuous measurement of patient outcomes should be a central research focus. And these are three things that I think we can do and have to do. And it's what really prompted me and my group to start the initiative called the Men's Health Initiative of British Columbia. So the next frontier is the Men's Health Initiative BC. Can you see the chandelier? I thought that was a cute chandelier. So I had to take a picture of it. It's very familiar. I don't know what it is about it, but it's just very familiar. So what I'd like to do in the next few minutes is tell you and convince you about the many reasons why a Men's Health Institute or initiative is an idea whose time has come. It's actually should have come 15 or 20 years ago. It's long overdue. So why do we need a men's health initiative? Men are one of only 2 genders on the planet. Recent media and commercial interest, there's been tons of it over the last 10 or 15 years in men's health, reflects an increasing focus of our societies on healthier living. You're going to hear a lot about that over the next day or two. Maintaining sexuality and aging well. I mean, you read about it. It's in People magazine. It's in Men's Health magazine. Population health, we hear that. That's a key buzzword. You know, how many have heard the word population health? That's a key buzzword in our healthcare system these days, and our governments are all talking population health. But despite significant differences that we already know exist between healthcare outcomes in men and women, men as a gender in general are not yet targeted as a specific research interest, or an at-risk population for that matter. So we have gender-based health challenges. Nothing taking away from women. Women are years ahead of us, but men, we have some catching up to do, because it shouldn't be this way. You can see men's health screenings are nothing but spider webs. They're not too busy. We have to be looking at risk assessment. We have to be taking men in their midlives and telling them, you're at risk of X, Y, and Z, and this is how we could possibly prevent X, Y, and Z. We're not talking about finding the fountain of youth like Ponce de Leon was searching for in Florida. For millennia, men have been looking for the fountain of youth. We're not going to find it. Mankind is just too complex a structure. I'm going to digress for 1 second. How many of you know about saw palmetto for BPH, for voiding? So you've all heard about saw palmetto. How many of you know where saw palmetto comes from? So let me tell you, only a couple of you. Saw palmetto comes from the palm berry in southern Florida. Now when Ponce de Leon, this is my theory only, it's not being published, it's Goldenberg's theory. The fountain of youth equals saw palmetto. I figure that Ponce de Leon arrived in Florida and started eating the palm berry fruit and found that his urination was improving. And he thought that he had found the fountain of youth. My theory only, I'm going to get back on topic. So, I mean, this is overwhelming. In the next few slides, really, really sorry statistics. I mean, it's overwhelming that men account for such a large proportion of accidents, of violence, of homicides, but not just as perpetrators, but as victims too. And men, in general, have a pretty challenging start in life. 80% of spinal cord injuries, substance abuse, violence, and crime are in males. 80% of autism occurs in boys. 75% of Tourette's syndrome in boys. 70% of developmental disabilities in boys. The trends are evident early on in life, as you can see here, and they just get worse as you get older. In teenage years, teenage deaths, 65% male. Homicides, 85% male. Teenage drownings, 91% male. Teenage MVA deaths, 65% male. Seems to be a bit of a trend here. Suicide attempts, 35% male, but successful suicide, 80% male. Cardiac death, 75% male, and men tend to die 10 years younger of cardiac events than women from cardiac events, and almost all workplace deaths. So men die 5 years younger than women, and their potential years of life lost, which is a measure of premature death, is also increased. So someone once said, why did Jewish men die before their wives? Because they want to. I just thought of that when I saw that. Sorry, I can say that. And this is in a graph form for those of you who couldn't figure out the last slide. Okay, so as you get older, the difference in life expectancy between men and women increase. And so there's about a 5-year difference in men, between men and women. And from the top 10 causes of death, we can see that men die at higher rates than women from the top 10 causes, about 1.6 to 1. And because of that, I'm not going to go through the top 10, because it's just a series of statistics showing the risk ratios of men dying from cardiac disease, from cancers, from motor vehicle accidents, and so forth and so on. But the end of it comes out in this slide. The ratio of men to women at birth, it's 105 males per 100 females. But by the time you reach age 85, it's 35 males per 100 females. And at age 100, 14 males per 100 females. Even at age 65, 70 males per 100 females. So there's a couple of ways of looking at that. One is false optimism, like the Beach Boys sang, 2 girls for every boy. But before you get too excited and say, bring them on, you better remember that you're twice as likely to be in the already dead category and not the having a great time group as a man. And Tom Lehrer from Harvard University, a mathematician, said, I mean, actually, Tom Lehrer committed suicide. He said, he put it, when Mozart was my age, he'd been dead for 12 years. So, women really do tend to take better care of themselves than men. And men, we got to figure out how we can do better. And some of the reasons are, we don't visit our physicians. We don't seek preventive care. We're not immunized as often, for example, with flu vaccine. And this is what I thought was an interesting perspective. When men have car trouble, they go to an expert, a mechanic. But do men visit the doctor when their body sends warning signals? A recent national survey found 84% of men say they've had their car serviced in the past year, but only 66% of these men have had an annual checkup with a doctor in the same period. It's a 20% difference there. So men notice when their car doesn't perform properly, but they don't listen when their body tells them it's time to see a doctor. And it's because men's health has no articulated community like women's health. We don't have institutional structures. We don't have a lot of resources, networks, chairs, academic chairs, hospitals, men's hospitals, and really very few, if any, champions. We got large gaps in men's health. So these are all things that we can learn from women's health and move forward in a men's health initiative. So we can learn to engage one another through communication and collaboration. These are excellent lessons that we can capitalize on. Develop a gender pride, establish contact with a physician at an early age, maintain a gender focus. But there still are, on our Y chromosomes, we have barriers to our men's health. You know, we're the strong, silent type. We were raised to be the providers, go up and be the harvesters, bring back the food. This goes back millennia. The bravado of men, risk-taking, strong and silent, take it like a man. Denial. So are men stubborn, stupid, or both? Is what I ask. Look carefully at this picture. Typical male. Trust me, those are male drivers. Don't be embarrassed. You think you're the first guy whose wife stuck the TV remote up his butt? So, in British Columbia, we've initiated the Men's Health Initiative. It's an umbrella initiative. It's dedicated solely to the pursuit of excellence in men's health, or women's health for men. It's another way to look at it. And it's an umbrella, meaning we're not trying to replace or to build a hospital tomorrow for men's health, or to replace all the foci of excellence throughout our community. We've got experts in prostate, we've got experts in sexual health and bone health, mental health, and so forth. But we need to bring everybody together under one resource package that will be able to optimize men's health. And by 2010, our vision is to have an institute that leads research and education in health promotion, prevention, and standards of clinical care in men's health. Through UBC, we have an academic mandate. We want to do research. We will lead in best practices, protocols, and care plans that will have to be distributed to our family physicians and specialists. We're talking about shared care versus a comprehensive care. Again, we're not building a hospital to provide comprehensive care. We want to develop the appropriate care plans and distribute those around the province and hopefully around the nation. It will be true interdisciplinary. This is not just a urological approach, though of course urologists deal a lot with men's health issues, but I don't know the first thing about mental health, and so I have to partner with my mental health experts. Strong focus on current status reports and outcomes analyses. So one of the first projects that we were going to undertake will be to do a men's health report card for British Columbia. Emphasis on health promotion and disease prevention. So as I said, we're going to do this report card and needs assessment. We're going to create a biopsychosocial database of men's health parameters, behaviors, and attitudes, in all of those areas listed: cardiovascular health, sexual health, or couples health. It takes two to tango. Testosterone deficiency and metabolic syndrome, prostate health, bone health, mental health, lifestyle issues, nutrition, risk-taking behaviors, disease impacts on health, family, and economics. We'll position ourselves basically as an inclusive umbrella organization. It has to be not just perception, but reality. And we are affiliated now with Vancouver General Hospital, UBC, and our local authority, our provincial health authority. Again, our emphasis is on research, coordination, and leadership, rather than overlapping or trying to take over or threaten people who have existing services and programs. So for example, in cardiac health, we have no intention of recreating all the educational materials about healthy heart and how to prevent heart disease or how to assess someone for the potential development of heart disease later on in life. That's all there, but we want to absorb it in, have links through our websites, be able to distribute that educational material under the umbrella of a men's health initiative. And the what's in it, the whipping factor for the people who are doing the cardiac is they would be part of a bigger organization with linkages for potential educational research partnerships with the bone health people, who they may not even know exist out in the community because their focus is on cardiac health and so forth. So the proposed direction is to improve men's health through research and leadership on promotion and prevention, treatment protocols, and health professional education. Of course, it takes money. We had a recent fundraiser in Vancouver, partnership between the Vancouver General and the Canadian Friends of Hebrew University for raising funds so we get some seed dollars. We have that in place now. We have ongoing fundraising through our groups, through our development people. We're going to leverage this with the BC government and other health authorities. Of course, our researchers will be applying for peer-reviewed grants, and we're looking for industry partnerships. Now, I want to just, as an aside, comment that I think it's important that we not be perceived as being in the pockets of industry or pharmacy, but rather as partners with pharmacy and industry. So the success will be dependent on provincial government, VGH, health authorities, needing champions for men's health, people who will get up on a podium and speak about men's health like I've been doing here this morning. Seed funding, we need a strategic vision with a clear mandated positioning and a governance structure. The governance structure that we've drafted is basically quite simple: a steering committee with an executive director, a men's health advisory panel made up of the leaders of these different action groups. So each action group would represent a module, if you will, of men's health. So you might have an action group for testosterone replacement, an action group for sexual health, one for bone health, and so forth. And I'm just going to list them. So, of course, most of the time people think about men's health. First thing that comes to mind is prostate, benign and malignant, and sexual function and sexual dysfunction. I mean, it's clear that those are extremely important aspects of men's health, but I point out to you that men are more than a prostate and a penis. So we have all these other action groups, which I've already alluded to: the mental health and psychosocial dysfunction group, cardiovascular health, other cancers, colon and lung, screening for colon cancer, bone health, testosterone replacement, metabolic syndrome, and other endocrine problems, aging male, general geriatrics and men's health, be it social isolation, depression, incontinence, nutrition, and so on, preventing falls, contraception and male reproductive health in the younger men, sport and fitness, gay men's health, boys and adolescents, risk assessment and stratification, really going across all spheres. So we hope that our outcomes with our Men's Health Initiative in BC will be that we will address the gaps in healthcare delivery for men. We'll do a BC report card, possibly even a national report card to follow, depending on the results of the BC assessment. We will be accumulating, developing, and distributing evidence-based recommendations for diagnostic and standards of therapeutic care, best practices for our physicians in the community and other healthcare providers, be it a guideline, an official guideline, an expert opinion, a consensus statement, whatever we can develop. For example, in osteoporosis, most GPs are quite confused when to do a bone mineral density. If to do a bone mineral density, as Stephen alluded to, it may not be the best test in an elderly male. When to treat people, how to treat people for bone health, and so on. So we need to, and Osteoporosis Canada has this material, but it's not widely distributed beyond a very select group. So we want to be able to enable and facilitate the distribution of this educational material. Partner with many groups. Hopefully we'll partner with CPCN for prostate health information and basically become a major resource for men. So we want to decrease this gap between life expectancy and health expectancy, grow older without growing old. I'm repeating that slide. And we can do that with early life interventions. I like to use the motto, let's add 10 years to the middle of a man's life. What's the point of adding 10 years when you're a cardiac cripple and, you know, fractured hips and lying around and just a nuisance to everybody? Let's add 10 years to the middle of your life, okay? So we want to maximize functional capacity, bone mass, and optimal body composition. Get people to get vaccinated. Promote healthy lifestyles with outdoor activities. You know, the old remote control up the butt story. Healthy nutrition, health and sex education. For men over 50, promote healthy lifestyle. And listen carefully to Dr. Moya tomorrow, because he's going to tell you all about healthy dietary habits. And I don't like to tell people, stop smoking and don't drink. We gotta let other people tell them that. Manage hormone deficiencies. Avoid obesity, which is running rampant through our society, and control high blood pressure and high lipids. Encourage periodic, comprehensive screening strategies, or call it risk assessment or case detection. Of course, PSA and DRE, I don't have to sell you on that. Colonoscopies, mammography, and pap smears for women. And control hypertension, diabetes, osteoporosis, and so on. The list is there. So there are things that we can do early on in men's lives, and we can encourage to add 10 years of healthy living to the middle of men's lives. So take this story home to your sons and grandsons. Tell them to get smart. So for the men here today, forget the bravado. Let's break the silence. Let's pull together. Let's work together. Because this project, I believe, is achievable in British Columbia and across Canada and perhaps across the world. We hope that the model that we create will start a revolution. And for the women today, I mean, it's clear that men in our society hold the lion's share of wealth and power, and have so for generations. Though I must say, in the last number of years, women are moving in, and they're claiming their power and their experience and their strength, and they're showing us their resilience. So we need women. We really, really need women to lend support to the male half of the world. Because if the women's groups and women in general are prepared to work with us, with the men, then both genders will stand to reap the rewards. So men need their partners to steer them. If you can't read that, it says, with this, I'm going to control your life. So let's seize the opportunity. Let's be world leaders in improving men's health and well-being. Let's not lose the lead. I think we can. This is a unique opportunity for the Vancouver community and for British Columbia and for all of Canada. And as Nike promotes, let's just do it. Thank you.